very good morning to one and all present here. Actually, a very good afternoon to one and all present out here. I take great pleasure to welcome each one of you who's seated in front of this dais. Because each one of you in front of the dais, be it our respective doctors, our patients, the respective media, and of course, Mr. Dinesh Gundu, the Minister of Health and Family Welfare, Government of Tamil Nadu, Government of Karnataka, who's here with us today. Thank you very much, sir, for joining us. Before I start, this is not something we normally do, but I'm going to request you all to please give yourselves a big hand of applause. Because the reason that we are present over here is because we have a heart to give back to a cause that is the need of the hour. As we all know, kidney disease is going to be the 5th killing disease in the next few years from now, and the top 3 in terms of diagnosis, and the number 1 as non-commutable disease. And if we do not wake up to this cause, I think we're going to be in a place where we're all going to kind of wonder where do we get started. So I believe today is the day, and I'm glad to be in the city of Bengaluru. Before we start the proceedings of this event, as per the Indian traditional custom, let's start with the lighting of the lamp, and may I request our respective minister, Mr. Dinesh Gundu, Vasundhara Raghavan, Dr. Shankaran Sundar, senior nephrologist. Srini, can I request you, Director of the Kidney Warrior Foundation, to please join forward. Dr. Zafar, from HPS Hospital, can I request you to join us forward, sir? And Dr. Arvind Kanchi, who heads our preventive measures along with Dr. Sundar. Well, now that we have the lamp lit and the blessings of the Almighty upon us, I think it's a good time to move to the next step for this event. And can I request Dr. Sundar to please honor our guest for this afternoon by handing over a bouquet and a shawl. Can we honor the doctors? Can we honor the doctors at the end of the program? Vasundhara? Thank you. So ladies and gentlemen, boys and girls, we are here, like I said, for a deeper purpose, and we are here for the launch of the Kidney Warriors Edition 2 book. Now this is just not a book. I want to call it the Bible of chronic kidney disease, because this is a book that talks about the grassroots problems that are part of our country. Through the stories of our patients, we have the government perspective, we have the nutritional perspective, and we have the medical expert perspective. And I believe this book should be the book in every home, because these stories should reach the end of the country and of course the ends of the world. Because stories like this will bring about the change that we are going to be talking about in this room. So to take you to the proceedings of this event, we are trying to keep it as short as possible, with just one panel discussion, and of course we're going to have our minister address the gathering post that. And on the panel, I'm going to request our panelists to please join us forward. We already have with us Dr. Shankaran Sundar, who is the Senior Nephrologist and Director of Aster Institute of Renal Transplant. Dr. Shankar comes with 5 decades of experience, and he also heads our preventive measures from the Kidney Water Foundation. Thank you so much, Doctor. And then we have with us Dr. Arvind Kanchi, who also heads the preventive measures for the Kidney Water Foundation. He's Senior Nephrologist, Trustwell Hospital. We have Dr. Zafar, who's requested me not to put him as a part of the panel, but he's given me some great inputs. Dr. Zafar is from HPS Hospital, somebody who really holds a very, very important place in the patient advocacy body, because he gave up his entire profession to give back to the community. Thank you very much, Doctor, for what you do. And then we have with us Dr. Maitri. Dr. Maitri is the Associate Professor, Department of Nephrology, Institute of Nephrologists. Don't judge her by the way she looks. Her experience is double her age. I think the work she's doing in research is just phenomenal. And the knowledge she brings to the community is just excellent. Thank you very much, Dr. Maitri. And Dr. Maitri will be representing the public sector today. And then we have Dr. Akila Vasan, Consultant Pediatrician in NH Hospital. I think somebody who studied in UK, brought that experience with her experience working in the UK and now in India. Somebody who has a large heart to give back to the pediatric community. And then we have Swati, who's not a doctor, but I think works very closely, because kidney disease, as you all know, lifestyle management is the most important thing. And we will be talking a lot about why people like Swati are game changers in this disease. And of course, we have one more chair. Ladies and gentlemen, please put your hands together for our partners on board, Bangalore Kidney Foundation. Now, these are the people who need all the respect and love, because I don't know if they know what they do, but they just do it so lovingly, so gracefully, only because they have a story. And we have Chandra from the Bangalore Kidney Foundation. And of course, we have our respective Minister of Health and Family Welfare, Government of Karnataka. So everybody seated in the panel, I'd like to put my hands together and say thank you very much. It's such an honor to share this space with you. And I have a few questions. We're not going to really have a structure to this, because I think we're all here for a common purpose. So I'm going to let anyone intervene in an orderly manner to have this discussion move forward. I'm going to start with Dr. Sundar first. Dr. Sundar, like I mentioned, you've been a nephrologist for the last 5 decades. You've grown with the disease. You've grown with the medical industry. You were a part, I remember you were also a part of the first transplant. Was that right, doctor?
More or less, my colleague was.
Yes. So you've seen how this progresses. So my question is, if 20% of people from the IT professional in Karnataka or Bangalore is on the transplant list, Dr. Anupuma's research says 6.5% of the rural area in Karnataka was diagnosed on a random search on CKD 3, 4 and 5, not 1 and 2. We still don't have that information. Dr. Maitri mentioned that the number of patients that are coming to the hospital is just doubled. Dr. Zafar mentioned today, the last year that we met him, to today when we have had a discussion, it has grown by 50%. Now, I don't think this is just the awareness about the disease, that people are meeting the disease. I think this is the growth in the disease. How alarming do you see this? And did you anticipate this 20 years back?
Marine rightly said, I came to Bangalore in 1985 as a nephrologist, that is nearly 40 years ago. At that point of time, people who come to us for dialysis were people who were very sick. When they didn't even know they had kidney failure, they were diagnosed with advanced kidney failure, they required dialysis. And when we started dialysis at the Ramaya Medical College in 85-86, people could have dialysis, or mainly, you could say, underworld dons, ambassadors, businessmen, it was like only they could afford. But things have changed. At that point, we never anticipated this sort of growth. But down the line, I think one factor has been diabetes, which is coming in. We are the largest diabetes population in the world. In fact, Dr. Mohan, the famous diabetologist of Chennai, says that we are the diabetic capital of the world. According to him, some point of time, every fifth Indian will be a diabetic. Every fifth diabetic will be an Indian in future. So imagine 1/3 of all these diabetics will get kidney failure some point of time. So we are talking not in millions, in billions of people getting kidney failure. That is one. Now you're talking about IT people coming, it's a very interesting point. I'm also seeing a lot of youngsters with kidney problem, going into dialysis, requiring transplant. It is quite mind-boggling. The numbers are staggering. Our health minister has been doing great service, offering free dialysis, number of dialysis units has increased. It's a great thing, but whatever we do is not going to be enough, because even a country like United States, they are not able to meet the dialysis population. They are increasing the dialysis numbers, machines, nephrologists. In fact, Arvind is going to the United States tonight to attend the American Society meeting. You'll be surprised to know there are more nephrologists of Indian origin in the American Society of Nephrology than in the whole of India. We are about 2,000 people nephrologists in India. There are more than 2,000 nephrologists Indian origin in America. So, in spite of that, they are not able to meet. So, what do we do? The numbers are alarming. One is, as we keep talking, is prevention. Awareness, prevention. There are only two ways we can do that. And the IT people, I think they are intelligent. And how do you prevent this disease? One is definitely lifestyle modification. Your weight control, diet, salt. Salt is one of the biggest culprits. It's a killer. In fact, now we are having a new theme coming in. Everybody talks of sugar. Chini kam. You've seen the Amitabh Bachchan movie. Chini kam. Now we are saying namak kam. Less of salt. That's going to be the, and you know, our health minister is here. The processed foods have a lot of sodium. That is salt. You go to McDonald's or anywhere, you know, good tasty food is a lot of salt. Because there's a Tamil saying that if you don't have salt in the food, you have to throw the salt in the dustbin. It's not true actually. So we have to go on this lifestyle modification, smoking, exercise, weight loss, and stress. Stress is very important. It's coming up every day. The IT people come and tell me they work 18 hours a day and they are having a lot of stress. They have a mental problem also, but it also adds to the kidney problem in my experience. Because when you are stressed, the blood pressure goes up. Negative hormones come in. And then once you have high blood pressure, then add to the lifestyle change of diet, you get kidney failure. So these are important things. I think we have to approach this kidney problem. First is prevention. Prevention is the most important. Treatment, we can do. We can have any number of machines. The easiest is to buy machines. Getting manpower is the next problem. But treating these people, it's a big challenge. A country like America with a lot of money is not able to do it. So we in India, we are doing a great job. We have a dynamic health minister who is taking care of offering free dialysis. It's not easy. But all dialysis units all over the world, the numbers are increasing. It's not going to be easy. So the short answer is prevention, prevention, prevention.
Thank you, Dr. Sundar. Yes, Doctor.
Since you said we could interrupt, so I'm going to add to this by giving you some numbers. And the numbers are the National Family Health Survey of 2019 to 2021, National Family Health Survey, NFHS 5, has shown that the prevalence of diabetes in the Indian population is about 16%. That is quite high compared to other countries. Also, if you look at the article that was published in the Lancet in 2023 June, you will know that India has 101 million diabetics at present. So it's quite a high number of diabetic patients. And like Dr. Sundar said, anywhere between 30 to 40% of those patients are going to end up with kidney failure. So you can see how bad that is. Dr. Anupama, who is a nephrologist and our colleague who works in Shimoga, did a survey in villages in Shimoga, and she found that 30% of people living in the rural area have high blood pressure or hypertension. So you can imagine how these two diseases, both diabetes and high blood pressure, are sort of on the upward trend, and this is going to cause more and more problems with life as such. Also, the NFHS 5 commented not only are there 16.1% of diabetics in India, but only 25% of them know that they have diabetes. And out of those, only 10% are in control of their diabetes. So if you look at all these numbers, it makes for very sorry reading. And therefore, the incidence of, let us say, heart disease, kidney disease is on the rise. The fact that, we just talked about the professionals in the software industry, obviously their stresses that Dr. Sundar mentioned, the fact that their lifestyle may be different, all that contributes to the fact that they are higher up on that list of transplants. Thanks.
Doc, can you go back on the data for the people who are diabetic and do not know that they're diabetic, Doc, that you just mentioned? Can you give us that numbers again?
So the fact is that 16.1% of the Indian population probably has diabetes. This is an NFHS survey that was done between 15 and 45 years of age. If you include more and more aged people, you'll probably get a higher number. From the point of view of diabetic patients who do not know that they have diabetes, only about 25% of patients know that they have diabetes and get treated. Out of that, only 10% are in control of their diabetes. So all this makes a sorry reading. And I'm going to talk to you about hypertension also, since you brought me into this area. Hypertension in India, anywhere between 16% to 30%, which we already talked about. In urban areas, upwards of 40%. A survey in Delhi says 40% of urban people have hypertension. Of these, only 30% of patients have their blood pressure under control. That's another problem.
Doc, since I'm going to continue with you once again, Doc, since you mentioned that a small percentage of these people are only aware that they are diabetic, the reason that they don't know, is it the lack of knowledge, or is it diabetic is so normalized as a part of every household? What, according to you, is your...
So in India, we are a reactive population. We are not a proactive population. We would not go for... So for example, most of us, including Dr. Sundar's team, and we have, healthcare camps set up, World Kidney Day. We offer free blood tests, free urine tests, free checkup, free blood pressure. Hardly about 50 to 100 people turn up in these camps. Imagine if we do a large screening of the general population and find out how many actually have it. That is not being done, and it is something that we'll have to look at and decide how to do it. For example, in Singapore, the catchment area is the military. Most Singaporeans at the age of 17 have to go into the military. In the military, everybody gets their sugars, blood pressure, as well as their urine tested for protein. This is where the catch is done of kidney disease. Here, ideally, I would say a government mandate. The minister is here, I hope he's hearing. A government mandate to look at how health screening can be done. How, for example, on a first, let us say, job offer to a person, why not do a screen at that point in time, where a job offer means that you do this health screening. You can then catch more and more patients with diabetes. We are a reactive population, I say again, we are not proactive. Nobody will come to the hospital and get themselves tested for diabetes. That is the reason we have this problem.
Thank you, Dr. Kanchi.
As Arvind was saying, Dr. Mani, my senior colleague and father figure of nephrology in Chennai, he has done a study of actually simple thing, going to the villages and just checking the blood pressure and a simple urine exam, that's all. Simple blood pressure test, because anybody with kidney problem will have high blood pressure, that's imperative. So so in the schools, if you can start checking blood pressure, that will be the start. I think I'm sure Akila will be able to guide us. So I think we can start from school screening, if not blood test, at least simple blood pressure check. So even I keep talking, you go to a mall, get a BP bottle, keep checking blood pressure, you can diagnose many of the kidney problem in that.
Dr. Kanchi, I'm going to catch on to your face that we are a reactive population and not a proactive, and that will take me to Dr. Maitri. Dr. Maitri, to bring in the shift within the Indian population to move from a reactive to a proactive, which means, I'm assuming we got to do something before it does something to us. So my question to you is, what are the most effective ways to prevent kidney disease and also to maintain kidney health? And I request you to look at this question as two separate questions, because in awareness we see people at different stages not controlling their kidney disease, for sure, and then on the preventive side as well. And we know that we've heard about salt, we've heard about sugar, we keep talking about it, we heard about stress. Could you highlight some of the points that are overlooked widely? Or if you have to even repeat these points somewhere that we have to start. Go for it, Doc.
So adding to the numbers of what Dr. Arvind Kanchi sir was telling, 850 million people all across the globe are affected with kidney disease. It is definitely not at all uncommon. 1 in 10 person is affected with kidney disease. And if you see diabetic, 1 in 3 has kidney disease. And if you look at hypertension, 1 in 5 with hypertension has kidney disease. And kidney disease is the 7th leading cause for death worldwide, and it is projected to be the 4th leading cause of years of life lost by the year 2040. So definitely we are on the upward trend. So the main risk factors for kidney disease is diabetes, hypertension and obesity as of now, and all 3 are on the upward trend. Unfortunately, kidney disease is a silent disease. It is asymptomatic disease. 80% to 90% of the people with kidney disease don't even know that they have kidney disease. And if you look at diabetes, as Dr. Arvind Kanchi sir rightly pointed out, 50 to 60% of the diabetics, 50 to 60% of the hypertensives don't even know that they have hypertension. And some of them who know that they have diabetes or hypertension, they're not on treatment. Hardly 20 to 30% are taking treatment. And less than 10% have their blood sugars under control or blood pressure under control. So definitely the only way to identify this disease, because it is asymptomatic, is to screen largely for the patients who are having the risk factors of kidney disease. Why screening is important? Because as I already mentioned, it adds to the morbidity and mortality. It reduces the quality of life of the patient, and you are very well aware about caregiver burnout. I don't think I should explain that more to you. You're all kidney warriors. And the economic burden that it has on the government and the patient's family both put together, it is humongous. So, of course, the repeated hospitalizations that come with it. It is a chronic disease, it is not a one-time disease. So that is exactly why it is very important to screen. And how do we go about screening? We have these non-communicable diseases program that is going on. Probably like screening for malignancies or screening for diabetes and hypertension. We should incorporate kidney diseases into that. All we need is urine protein, that is for urine protein estimation, and serum creatinine levels. That's all. Only 2 tests we need. Maybe sometimes ultrasound. And these 2 tests are not all that expensive. So in the program that is already going on, when you're already screening for diabetes or hypertension, door-to-door screening, or if you're screening for malignancy, you just add these 2 to it. You don't have to come up with a new team or a new plan. Or maybe something like polio vaccination, where you go door-to-door and give polio vaccines. So incorporate kidney disease into the already existing programs that I think our sir is here. he must help us out by including kidney diseases into the non-communicable diseases panel, and also empower the primary healthcare sector, make them aware that the population that the primary healthcare sector the PHC doctors are taking care of, at least they identify high-risk population. They don't have to screen the entire population. Screening entire population is not at all economically effective according to the studies for the government. So just identify the high-risk ones, that is diabetes, hypertension, obesity, those with family history of kidney disease, or someone who has already had acute kidney injury, or congenital abnormality of kidney and urinary tract. So identify the high-risk population and just do screening in that particular population. That would be more than enough. Just in the primary healthcare sector, just empowering our nursing staff or the dialysis technicians or the pharmacists, that would be more than helpful for us. Of course, we need the support of the government for that.
Doc, I'm going to continue with you. While you say all this, and it sounds so amazing. But most of us in the room somewhere have been there, done that. We know it's not as easy as it sounds, considering the population that we have. So let's be practical. What, according to you, as a medical practitioner, could be a process that we could put in place, be it with, if you work alongside the government, the medical fraternity, the patient body, and multiple other NGOs who are present over here. Do you have a thought in mind of how do you make this possible?
Yes, actually we had come up with a plan, one is this empowering the grassroots level healthcare workers. The grassroots level healthcare workers are these we have to take help, support from others as well. We can't do it all alone. Nephrologists alone can't change the world, bring about revolution. So the grassroots level workers would be Anganwadi workers, the nursing staff, the dialysis technicians, the pharmacists, and the PHC, primary healthcare doctors, general practitioners and general physicians. And we also planned of coming up with a curriculum for the non-nephrologists. It is called, I was talking to you about that. So that is created by the International Society of Nephrology. I was one of the faculty mentors for it. It is called as Nephrology for the Non-Nephrologist course. And it is conducted once in 6 months. It is offline, face-to-face, so that where we educate the non-nephrology population, non-nephrology community about the importance of screening for kidney diseases, whom to screen and how to manage and stuff like that. And also there is a curriculum in the International Society of Nephrology website where it gives you a toolkit on whom to screen, when to screen, how to screen, and when to refer to a nephrologist. So that toolkit is freely available. It is provided in combination with International Society of Nephrology and KDIGO. Both have come together and put up the toolkit. It's just one page. Only thing is we have to disseminate it across our healthcare workforce. You know, the healthcare workflows is already overloaded. The doctor to patient ratio is not as good. The number of doctors or the healthcare professionals working are very less compared to the population that is already there. There is burnout, and of course they're always busy. I mean, the number of patient load that they have to see is too high, and there are guidelines coming in every now and then. People are bombarding with guidelines, so we have to take care of the healthcare workforce as well.
Thank you, Dr. Maitri, for actually bringing that point in. I'm glad to know there's a paper that is there for the other multidisciplinary specialists, because while the paper exists, as the patient body, I strongly believe that it is not there in practice. Because we see everyday patients whose disease could be stopped at a much earlier level, but because of the lack of coordination between the specialist, the two specialists, eventually the patient is moving on to kidney disease. And I believe in the medical fraternity, if there was this interdepartmental functioning, I think the patient would be the center of everything. And I really believe that that's a fault of the medical system. And I really wish we could do something about it, but I'm glad to know there's a paper, and we would like to use it in future while we work with other specialists.
I can share it across.
Thank you so much, Dr. Maitri. Dr. Zafar, I know you told me not to ask you a question, but this is your point, so I'd like to put it across to you itself. Doc, you mentioned to me that there is a 50% growth of patients that are coming into HPS hospital this year. Now my question was, is it because of the fantastic work HPS is doing, or do you see a growth? And you mentioned you see a growth. And like we had our doctors talking about salt, sugar, stress, you gave me a very, very different perspective. Because you are dealing with the lower economical class citizens. And your point is, one of the main problems, and I can tell you this is the case study of my husband as well. One of the main problems is medicines across the counter, where patients, anyone can go and meet the pharmacist, pick up medication, and very interestingly, the person who gives us the medication is somebody below even the age of 18.
Yeah, sure.
And this is an alarming news. So what do we do in that place that you think is practically possible? While we have the law saying it cannot happen, but clearly it's not happening in our country, what according to you can be done, Doc?
You also mentioned, already they told about hypertension and diabetic, that is two causes. If what we are getting is already patient has been diagnosed that they are having hypertension and BP, but they are not getting the treatment. One thing is they don't have resources. Secondly, they are dependent on the pharmacist who is everything for them. Most of the pharmacists, what I see in that area, they are not qualified pharmacists, and they give any medicine without prescription, except few narcotics. But most of the drugs, especially the painkillers, they give without anything, without thinking what they are giving. And my patient or all the BPL category patient, they all depend, most of them depend on the pharmacist more than the doctor. Either the doctor is not available, or doctor is very costly, or some other outlet is there for them. Either they avoid completely allopathic medicine, they go to magic treatment, drinking water and I don't know what at all. But this way, even they diagnose, they go to the terminal stage, and finally they come to dialysis. So it should be prevented at this. I feel that pharmacists should be screened properly, medicine should be given properly, and this, as doctor said, screening should be done more vigorously. See, it is like this, if you diagnose, it's okay. After diagnosis, what will you do? Will you them to go to the village, live as before? No, you should treat them. That treatment is very difficult. Now I feel that most of them, even those doctors said it is only 10% or 25% diagnosed, they are taking proper treatment. Even that, I'm sure about 5% are not taking treatment properly because of cost, because of not availability of professionals.
Well, basically pharmacies should not be able to dispense medications without a prescription. We need to bring a little bit more stringent laws. I think that happens in the rest of the world, and it does. We need to get that here.
And Dr. Akila, since you have the mic in your hand, it's a great point, but also let's be very practical of how our country works. Everybody's a doctor, whether you have, everybody's got something to offer you, and it comes from a place of love, okay? While the point that you're making is a part of the law, we all know that. What we should do in order to see this not happening?
Yeah, I mean, like I said, at least certain important medications, like say, NSAIDs or antibiotics or antidepressants and things like that, maybe anticonvulsants and stuff like that, which can have an impact on the kidney or the liver or anything of that sort. Maybe those group of medications has to be, should not be prescribed without prescription. Maybe paracetamol can be over the counter, cetirizine can be over the counter, but important medications which can actually have a side effect on the liver or the kidney, that should be based on a prescription, is what I think.
The point is very valid because in my area, my apartment, the pharmacist who is there, he is more doctor than
Exactly.
engineers.
Yeah.
He is able to treat and he is more popular than the doctors. The other thing is, if you look at the apps like the Apollo app or the Tata app for the medicine, I think there they insist on prescription.
Yeah.
But these follow the thing. So they bypass the app and they give discount also.
Correct.
The pharmaceutical gives more discount than the app follows, so that's why they are more popular.
Doc, the point that you're making is very important, and if we have to be fair to the emotional part of this point that you're making, that there's this emotional trust, there's this trust that they have on this individual. So in my head I'm thinking, instead of going backwards or pushing the pharmacist back, you remember the case that we spoke about hypertension, of how the person who did the research on hypertension used the pharmacist as a person to do such fantastic research. So do you think it's practically possible to empower the pharmacist, instead of pushing him back, to empower him to be a part of this game-changing work that we're all doing? Do you think that's practically possible?
I think it's an excellent idea. I think we should have more meetings with the pharmacists on how this could be done. Because we have to involve them. As like you said, they have gained the trust of the people and people go by that. If you can tell them what is the problem, if he is doing that, so I think the pharmacist can check. If he's giving some antibiotic, or he's going to the doctor, I think it's a very good idea. I would strongly advocate that. We should probably talk to more pharmacy people. But the problem in our country is the pharmacy is run in the name of the so-called qualified pharmacist. But the fellow sitting there is the 6th or 8th standard person. Because I know for that, because my mate's son is only 8th standard and he's assisting the pharmacist and he's giving diagnosis and everything he's treating.
And I think that's where the legal action should be taken, so that people are aware that you need to be qualified to be a part of the system. Dr. Akila, since you have the mic in your hand, my next question to you is, we've all been quoting WHO's prediction that is 2040, 1 in 3 people could be diagnosed with kidney disease, which means we are looking at the babies in our country. Now that's a very emotional point for me, and I can imagine how it must be for you. So my question to you is, what are the overlooked protocols at 3 different levels, but since we are running short of time, I'm going to request you to first only talk about prevention for kidney disease in children. And also, Doc, since you've been educated in the UK, you have your practice in UK. If you can draw parallels of what is happening across the globe, and something that we can take from them, and I'm sure there's something that we can give to them as well.
Sure.
If you can highlight a little bit on that.
So I'm a consultant pediatric nephrologist, so I'm going to be the voice for children, right? Okay, so I would like to get your attention on 3 different aspects. One is pre-dialysis. So number one, I would say we should have some screening programs involving, whenever children come for vaccinations and things like that. If they can simply have their height and weight checked, and if they're below the 10th centile for a particular age group, right? Those normative data we can give them. So say for example, a 5-year-old, if they're less than such a height, then they are less than the 10th centile. Usually growth is affected in any kind of chronic disease, right? So we don't have to screen the whole lot of children. We can screen those children who are sure and do some simple tests on them. And in that way, we can have screening programs which can be carried out by ASHA workers, Anganwadi workers, in all those places. This is a very simple tool, just measuring the growth. And if we incorporate them into our screening programs, that would be great. So these are the ones who will be referred to a district hospital, saying that okay, do some basic tests for them. It will not cost much of money. That's number one. And also, in children, preventing kidney disease and early detection of kidney disease is very important, because the whole point is not doing a transplant quite early in life. A child, if at all needs to have a transplant, we need to have 2 or 3 transplants for the rest of his whole life, right? So managing chronic kidney disease is absolutely vital. So that's one. And in children, the kind of diseases which affect and lead them to have kidney disease is congenital abnormalities or hereditary disorder, inherited disorders, kind of thing. Unlike the adults where it is diabetes and hypertension. So I would like the government to have certain schemes, at least for these children who've had these congenital disorders. Maybe can we include transplant as a part of like Arogya Bhagya scheme or Yashasvi scheme, whatever it is. Some sort of government scheme where only the transplant is made free of cost, only for children. Not for transplant. In the Institute of Nephrology, but that should be extended to the private institutes also. Maybe we can negotiate a lesser price or something of that sort. Yeah, because to be very honest, the expertise of doing pediatric transplants, in Institute of Nephrology, there is no pediatric renal transplant, right? There will be adult renal transplants. You can do, but generally it will be adolescents. They will be quite jittery to do it in 5-year-olds. Yeah. Say for example, in Narayana where I work, we have transplanted a 2.5-year-old kid with a kidney transplant. That, I'm sure, will not happen in the government sector. So we need to understand that the expertise also. Yeah, sure. Sorry.
You can't say that for sure cannot happen in a government sector, because I come from the Institute of Nephrology. We can definitely call expertise. If we don't have the expertise to do, we can call them from outside to do the surgery, and then we can of course follow up the patient. It is definitely possible. Only thing is we have not got that kind of a patient till now, because most of our children are on peritoneal dialysis, and we have not got 1-year-old or 2-year-old.
So, sorry, I didn't mean to demean you, but rare case. Yeah, so basically, at least even if children with because if insurance is not going to cover congenital disorders or genetic diseases, at least what as a government we can do is maybe give them subsidized rates for transplants. If in the private sector, if they're already doing the free transplants in the public sector, that's absolutely fine. Now the other thing is, there are some expensive rare medicines, for example, Cystagone or Eculizumab and things like that. Can we subsidize them or maybe take out the tax or import whatever duties which we have on them, so that at least it can be available at a lesser price to people, because that's quite important, and that's something which can be easily done. So that is focusing on the pre-dialysis. And with regards to the dialysis group, I would say that in every taluk in Karnataka, if we have a facility for children to have dialysis, right? And we can, the expertise can, in Bangalore itself, there are 5 centers who practice pediatric nephrology. We can all take turns, we can do some telehealth, service. and we can liaise with all these different, different taluks. In that way, dialysis will be provided closer to their home for children. I think from a pediatric perspective, that would be great. Now, with regards to the transplant, what I want to say is we have a list, waiting list for transplant, which is mixed up with the adults. I would definitely want to, vouch for a parallel list for children, because small donors, small recipients should have small donors. Right? You can't have, plug in a 40-year-old kidney into a 2-year-old child. So if we have a simultaneously parallel pediatric transplant list, that would be great, and that would actually, promote. Children, say for example, if they're brain dead when they're 3 years, 4 years, 10 years, then we can find size-matched donors. So please, take this particular thing into consideration, because that would be really useful. And because majority of the children who are dying are less than 5-year-olds, because they don't have, donors or size-matched on the waiting list, or they're too, fragile. They're very, complex. Yes, no, that's right. I'm saying we should have, so they can be on the main list, wherein 40-year-old can give to a 15-year-old or 17-year-old. But in addition to that, we should have a parallel pediatric list.
I think Bharat is saying that such a list is not there in Karnataka. We can get points.
Yeah.
Child should get more points.
No, we can get points in addition for the parallel list. We can make a point-based system, wherein based on their criticality of the patient, and based on their access difficulties or whatever it is, then they can get some points and they can be pushed up. So
is there any statistics? What are the number of children on our waiting list?
So basically, if you take any there is, say for example, if there are 100 patients on RRT, 1 to 2% of them will be children on RRT.
No, I don't know. I'm asking a question on already in the current waiting list. Are there many children? Not many. So the problem, what happens when you have a donor? Sometimes I find they're using both the kidneys for an adult donor.
Yes,
but they don't have a child with the...
Exactly. So that's exactly what happened. Like last month, we had a 3-year-old donor, wherein we took an en-bloc kidney, put it into a 40-year-old female who's done well. So the 3-year-old donor has done, saved 3 lives. Has saved a 3-year-old with a liver problem, has saved a 1-year-old with a heart problem. But I think we should promote that even more by creating a parallel list.
Thank you, Dr. Akila. Dr. Akila, thank you for bringing up all those points, but one thing that really caught my attention was you're available for service.
Yeah, so one more thing on the education aspect of it. So say for example in the movie theaters and everything, we have this, smoking kills, and we have these short advertisements. Can we have something about organ donation? Because I'm a part of Rotary Club of Organ Donation, and if we have small, advertisements about one minute or something, be an organ donor or something of that, we can reach masses. And if you can make that possible, we can, we have the expertise to create those advertisements or whatever, and we want that to be implemented. And going back on that, say for example, anybody who's getting a new driving license, right? When they're having their theory tests, can we have like a 1-minute video about organ donation? Would you want to become an organ donor? If they say yes, it gets integrated into part of their license. So I think that would be really good, because see, who are going to be brain dead? Majority of them are road traffic accidents. Right?
Make it part of the learner's license.
We could make it a part of the learner's license. I think these are the important points which I really want you to hear and take it forward, because we as a doctor fraternity will be able to help you.
In fact, I was suggesting I have it in the school curriculum, which happened.
Dr.
Yes.
Sundar, I'm going to get over there, but I'm going to go to Swati. So Swati over here is, while we all are looking at Mr. Dinesh when we make our points, I think Swati is going to be looking at all the doctors when she makes her points. So Swati is a nutrition specialist, and everybody over here knows that CKD is a disease that's completely based on lifestyle management. Yet, leave general public, even patients on kidney disease do not have enough knowledge of every stage of kidney disease, the lifestyle, your diet changes. Even they do not have this knowledge, and that has been a huge contribution to why they move from one stage to another stage. And like I was talking with Swati, we should have specialist nutrition, as in for renal nutrition there should be a specialization, and of course other lifestyle diseases, which is not there, I'm not sure across the world, but it's not there in our country. But we have people like Swati who specializes in renal nutrition. Swati, what is the reality out there when we talk all these fancy terms over here?
This is such a broad topic to be speaking about. But it's really my pleasure that I can share my thoughts here with all of you. Firstly, you said there's a lack of education. Honestly speaking, there's no dearth for education. It's just that the patients are not using the right people. Okay, social media has taken the world by storm. So they're either overexposed to the wrong aspects, or there is the other end of the stick where they have no idea whatsoever. And like you said that everybody in the world becomes a doctor when it comes to health. I'm sure everybody will agree that even when there's somebody who's pregnant, even the milk woman, the florist, everybody is giving you free advice. And invariably, it's that free advice that is sitting in the mind than for them to make up their mind and see a specialist. So I think you being in contact with both the doctors and the patients, I would request that you talk with your GPs, you talk with the doctors to emphasize that, when it comes to renal, just an intern doing nutrition cannot really help that patient, because renal diets are by far the most restricted. Even down to water and salt is restricted. And it's a dead end, literally. Either it's dialysis or transplant. There's no way that they can, if somebody has a fever, you tell them eat this for this while and then you get better and you eat normally. That's never going to happen there. So you have to really use KWF as a, I think that should become your motive, to encourage doctors, to encourage hospitals to hire experienced people. We are here to give, and as you know, I do a lot of free service. So we are there, but hiring capacity of the hospital, I think from cost cutting, I think I would like the minister to really address that from your point, you mentioned that specialty diet has to be on the forefront as well. Like every hospital should have somebody to specialize in those things. Or if not every hospital, at least a point of contact where, because it's monetary for everybody. Patients are not going to spend much and come and see me because I'm a freelancer. On the same front, I would also like to do free service, but it also has to help me, right? So it works both ways. So as a non-communicable disease prevention, yes, but again the fitness industry has taken it by storm with all these protein supplements and the capsules, and everybody thinks they're protein deficit. Nobody's really having themselves evaluated. So I think meeting the specialist, absolutely necessary. So pretty much numbers, everybody has spoken, so we all know it's staring in our face. It's just about how we try to, put it into action. I don't know if that answered your question.
I'm going to add an additional point to what you spoke to me, because you're trying to be nice here, but I'm going to still do it. While we have the nephrologists sitting and always voicing their opinion about multi-specialist, need to understand the nephrologist has a certain role. Don't try to be a nephrologist, is what I hear most of our nephrologists say to a cardiologist, a diabetologist, a gynecologist. And I'm going to represent the voice of Swati because she's a part of the patient advocacy body. I think a lot of nephrologists become renal specialists, diet. And I think as a community, I think nephrologists should encourage people like Swati, who's giving back service to the country, to the patient body, to do what they do best. It only takes away the load from the nephrologists, because we have trusted people, especially Karnataka. We've got the best of renal specialists in Karnataka. We need to support them in their work. So this is my request to the nephrologists seated over here. It's very important to encourage work like this.
I'm going to respond to that and say that most of my patients who come to me, I actually send them to the dietitian, because diet is a very important part of treatment of these patients. The only problem is the patient just skips that appointment. They just don't go to the dietitian. And that is not right, but it's very difficult to convince the patient, look, Diet is very important. That's one thing. The second thing is, despite going to the dietitian, they will not stick to the diet. That is another thing that is, I think, again, proactive versus reactive. I'm fine, just the creatinine is abnormal, I will eat anything that I want, nothing much will happen to me. But they don't understand the nuances of how actually sticking to a diet means you'll need less medications, and perhaps we're going to be able to save your kidney function. And this is a problem. Our impetus are sort of educating the patient's minds on looking at lifestyle modification is extremely difficult, because lifestyle modification by itself is extremely difficult to do.
Dr. Arvind?
Well, I was just thinking the point what Swati said about that. Maybe the dietary prescription should be part of the consultation fee of the group. Something like this, make it part of a package. Maybe that will work, I don't know.
Yeah, that's exactly what I was going to say, doctor.
I think that will, otherwise not going to work. The moment you tell the patient that he's already paying me 1,000 rupees fees, another 250 rupees he doesn't want. To be honest, so most of them they don't go. And I do send to dietitians, but I definitely send to dietitians who patients who go on eating my head.
Attention to a nephrologist over here, okay? While we are seated here at this press meet, we are looking at Mr. Dinesh very generously demanding, do this. I think this part of it is in the hands of the nephrologist. Because at the end of the day, a regular Indian citizen, God is in form of a doctor. If you say something, if you say something, it's like Devavaka. And as an educated caregiver, I'm telling you, if the nephrologist is not able to get the patient to do something, then I don't think it's convincing enough. I'm sorry, but I really believe when I say this. So you have to make it mandatory. If you meet me next time, you've got to meet the dietitian, else you're going to go down the drain. And the moment the doctor says this, trust me, the patient will go running and finding the nephrologist.
Especially in children, it's very important. They have different calories for different age groups and proteins and everything, and they have some special diet, etc. So, a dietitian plays a very, very important role. And without them, I don't think I could, carry out my practice.
Thank you, Dr. Akina. I've just taken the liberty to say this because I've got...
We need to understand, see, it is not general dietitian. See, they actually don't know, in my opinion, unless they're trained in nephrology, like Swati is trained. Because, like, invariably, the moment you say kidney problem, there's a low protein diet. My vegetarian patient doesn't take dal and is spoon weak. I don't think in India, low protein diet is needed. That's what I mean, all nephrologists say. But Swati is, because she's trained, but if the person is not trained, they'll invariably put them into so low. The Jains are because they're already on low protein diet.
Correct.
Because no protein.
Swati, I have one last thing. I have a proposal for you. You should create an app wherein the patient, will pay a nominal amount or something. So whenever, before he's eating, what's the kind of potassium, what's the kind of phosphate, what's the kind of, calories. If you can work with some sort of a computer guy who can create an app and specifically for renal diet, that would be great.
I'm going to pause.
Dietitians have done a great job. Dietitians have done a good job. Dietitians keep calling me.
I have no doubt of it, but I'm going to pause the discussion.
Your support, because we do not have labeling practices in place.
Yes,
That's
We will get back to that. We have Dr. Arun Gupta, for those of you who don't know, who's doing fantastic work across the country. We can connect on that. But I think it's not very often that we have a government representative seated here so humbly, so lovingly, and hear us out. And it's very important to honor that time. Yes, and I genuinely mean this, sir. Thank you so much. It means a lot to us. And I know we have somebody over here, but I think the main point of having Bangalore Kidney Foundation is because I thought, do you all work with the government already?
We do.
We do. So great. I think having a representative from Bangalore itself will become a point of contact for doctors, the government, and foundations like us. Of course, KWF is always there to support. But if I'm going to give you just a minute to talk about the free dialysis you're doing, and then we'll have our minister close and respond to all the questions you'll put across.
Thank you so much. We do 50,000 dialysis a year, out of which more than 50% is for free, and all women are treated for free in our center, irrespective of their financial situation. And our belief is that we don't want them to come to our center eventually. So we want to promote transplant. So it's also very difficult for patients to enroll into transplant because they have their own fears of financial burden, of success of the transplant, and also from the donor side, because transplant means two people. So how do we finance them, and how do we make sure at least for that 1 year after the transplant they lead the proper life as prescribed by the medical fraternity. So we would also need some government support in the transplant activities, because that's where you said it, we are at a dead end. Either it's dialysis or transplant. Dialysis is a lifelong situation, but transplant is the exit for these patients. And we've also seen that kidney disease is actually there is less awareness about kidney disease. So we have to increase the awareness of that. And it's actually worse than a heart disease or a lung disease or any other disease. The life of a kidney patient is actually really a wasted life. So we want to bring that life back to our fold. That's what we strive for.
Thank you, Chandra. And for our doctors who are present over here, the media is present over here, these are our partners in Bangalore Kidney Foundation. Please follow up with them, because these stories should meet and extend to the extreme ends of Karnataka. I think they're doing a fantastic work, and let this not be a one-off. This is for my respective friends from the media. This should not be a one-off meeting. This should be a start to a new journey. And with that, we've heard from our panelists, but then, Mr. Dinesh.
Thank you. So, firstly, I think a word of appreciation for the kidney warriors for the tremendous work that they're doing. And also congratulations to them for having brought out this second edition of this book, which looks into various aspects of kidney treatment, care, and also the kind of situations that people suffering from this go through. So I think it's filled with many testimonials and case studies and all that. So it's a wonderful thing that they're doing, and I'm sure that this will really help in people to bring about greater awareness and also to see how we can improve the existing systems. And of course, there are many well-established experts from the field who are there in this panel discussion, and it was indeed a very good discussion, and they were raising very many relevant points, and I didn't interrupt any of one of them, because if I get into a conversation, this program will go on for 2 hours. So I just stayed quiet, so that, because I also have got a time limit, I also have to go somewhere else now. So I didn't want to interrupt anybody, so that let them finish whatever they had to say. So many relevant and many important issues have been raised, and which we are also well aware of. Of course, the first issue which was raised by Dr. Sundar and Dr. Arvind also about the impact of diabetes and hypertension, and this is a well-established fact. So the thing is, the biggest problem is how do we screen them, how do we treat them, how do we get into the preventive. In fact, I think we are launching a very ambitious program, Karnataka government, which will be done on the 24th. And this program is a highly ambitious one that we are doing. And it is, in fact, exactly what you people have said over here, that we will be screening the entire population above 30 years, going door to door, house to house, checking everyone. And we've established certain protocols of how to diagnose, whether they have diabetes, whether they have hypertension, and what kind of medication needs to be given. So a lot of process and thought process has gone into it. And on the 24th of this month, we have called the program, this project, Griha Arogya, that is home health. So Chief Minister will be launching it. So that is one part of it, screening it. The second part is already, again, all of you have said, that we screen them, we test them, and then what? We may give them medicines for 15 days, something, and then after that they take, and then they forget about it. Some follow it up, some don't. So now what we have done is, we are ensuring to them delivery of the medicines to them, to all the people who are diagnosed across the state. So for hypertension and diabetes, we will be free delivery of medicines either to their households or to the nearest, we have a lot of sub-centers. So they can come once a month, pick up whatever stock they need, and they can take it back, or if they are old, or if they are aged, or if they are, are not able to come, our people ourselves will go there and give it to them at their house. So it is a huge program, and I'm sure that this will have a long-term consequence, nothing I think in the short term, but if it is done successfully, and it will be implemented across the state, and I think as we implement it, we will learn more how to make it more effective. And I think that is the one way forward, I think, that we have devised to see that people are diagnosed and people are treated. So even if I achieve about 60 to 70% of this, I think it will be a tremendous success. Because looking at the figures, we know that, like just now you said, nobody gets checked, and even if they get checked, they don't get treated. So that is one of the things that we are going to be doing. So that is one thing. The second thing, of course, is issues concerning, you spoke about transplant and how we can treat them and all those things. Now, as far as treating goes, we have, last year we increased the number of dialysis centers to more than, earlier it was 170, now we've got about more than 220 free dialysis centers across the state, in all talukas and in all urban areas. So we are giving free dialysis. We've got more than, I think, close to 850 machines. And we've also converted all the machines. Earlier it was multi, now we've all got single-use dialyzers across the state. So that is something that we've done now. So it helps in easier care for the people and less infections. So we've switched over to single-use dialyzers. Also, last month we came out with another, we approved, the cabinet approved it, which we had proposed that anyone who is doing charitable work in giving free dialysis to the public, we will give from our side 500 rupees per person, per dialysis. So there are many charitable institutions who are doing for people, and to them we will give from our side 500 rupees to help them to run it more efficiently. So, and along with, so to promote it for people who are doing it. And also, certain other hospitals who want to run, especially in the our Karnataka region, we have now opened up for even private hospitals for them to, and we will support them also. So that's another initiative that we have taken. And so those are the two major things that we are doing. Now, apart from that, there are issues concerning what you have raised regarding the pediatric. Of course, we have got the Indira Gandhi Institute, which handles the Institute of Nephrology, and Indira Gandhi Institute, I think, no?
Yes.
Yeah. So they are training people with, and it's also a center for excellence for all rare diseases and all that. We are using that. So I think we can look at your recommendations, how we can probably slot the child, maybe give it some sort of preference. But if you can give your suggestions in writing, you can just mail it also, or you can whatever, and definitely we will look into that. How we can streamline it, how we can make it more effective, and definitely we can do that. And of course, your issue is about nutrition, and yes, I think, we have, as far as government goes, we have our nutrition programs, and we are, see, this also comes under our department, in the sense that food safety is our department, and we are trying to see how we can, you may be noticing nowadays that we've been doing a lot of activity on all this usage of all kinds of preservatives, chemicals, artificial colors in food, and we've been taking a lot of action on them. Like cotton candy, kebabs, and gobi mushrooms, and again, a lot of tests we are doing every month now. We take a drive across the state on various food items, and every month we publish a report, and we publish our findings. So that one is we are educating the people, because a lot of consumers don't know that what kind of harm can happen by consuming the wrong kind of food. And also many of the people who make the food don't know. They think it's okay to just do all these things and and it's fine. So Now if you see, you don't see any pink candy now. You only see white candy everywhere after we banned the right now. So that is one thing that we are doing. The second thing is on AMR that you are speaking. Even AMR also we've taken up a drive that we're doing decoy operations on all these pharmacies, and we are finding them out, and we are finding them, and certain people we have suspended. So there is another thing that we have, but it has to be scaled up even more. I think antimicrobial resistance is a serious issue, big issue I think, and it has a major impact on health. And for that we are coming out with a special program which we should be launching by next month, where on this itself we are going to be really concentrating on how we can prevent antimicrobial resistance. One is over-the-counter sales, one is the way we dispose of our antibiotics. The other thing is how antibiotics are used on animals, in veterinary sciences, in our chicken farms, poultry. Everywhere there is huge abuse of antibiotics. Then hardly it's controlled or looked into. So we are bringing in all these aspects into it and trying to focus on how we can reduce this antimicrobial resistance. That is really because the amount of antibiotics we are taking, Indians are taking higher amount of antibiotics. So we are looking at all these aspects. So I think whatever you have spoken over here is already something which is already there in front of the government. And we are also taking steps and we are taking remedial action. So I'm sure that this is a never-ending process, and government's inefficiencies are always there. But how we can make it more efficient, how we can use technologies, how we can, all that also we are working on. So any suggestions you have, definitely we will look into and we will try and adopt them. In fact, we have written out a lot of syllabus material to our education department. And we said that we should include this as part of the child's education. So they have said that from next year at least we'll try and bring them with no textbooks. That is how for children to get educated on the lifestyle and the kind of foods that we eat, the kind of habits that we have. At a younger age, if they realize that these things have got real impact on their health, especially eating junk food, processed food, and all kinds of other abuses. So it should become part of their curriculum. So that is also, we've written out the whole curriculum and we have sent it to the education department to look into it and make it part of their textbooks. So I think whatever you said, we've been working on. So I'm happy to say that we are addressing issues, but there's always scope to do more, and definitely we will try and do more. So I want to thank all of you for having organized this event. I didn't know it was going to be like, I thought I'd just come 10 minutes, speak on the book and go off. But certainly I realized it's a panel discussion, but it was a very interesting discussion, and it was, I think, informative also. So it helps me also to think on issues and what we're doing and how we're doing. And you can feel free to contact me anytime, and my doors will be open. Thank you.
Thank you very much, Mr. Dinesh, for all the work.
The way you're going to do the screening work, I think we have called out of this.
Mr. Dinesh, I'd like to say one thing. I think the most exciting news that I've heard today is bringing preventive at the educational level. I think that is the game changer. Thank you so much.
See, because the curative, I think there are lots of people who do curative work. They do, hospitals do, everyone does. But preventive, nobody will do this except the government. Along with that, some NGOs, some foundations, they can help, they can pitch in. But otherwise, there are not many options. For a curative, they can either come to a government hospital or they can go to a private hospital, they can go to a nursing home, they can go anywhere. But for preventive work, I think it's primarily the responsibility of the government. And that is what we need to focus more on.
And this is for Karnataka, sir? Okay, then I'm going to come to you to take it to Tamil Nadu, please. and you please help me out, sir. Yes, because that's something that we've been working with schools and we realized that's the need. Grade 7, 8, in fact, we were talking about 3. And well, let's move on to the most important part, just the last 2 minutes. Ladies and gentlemen, we're actually here for the launch of the Kidney Warrior Edition 2, a book that is the game changer.